What is multiple gestation or multiple pregnancy? We have heard about twin pregnancy, triplet, quadruplet, At the time there is more than one baby present inside the uterus. This is known as multiple gestation or multiple pregnancy. Now, according to the definition, there is more than one fetus at a time. Okay, at one pregnancy, there is more than one fetus. And according to the gravida, according to the gravida, even though there are more than one fetuses, gravida is always one. One gravida is counted there. And parity is also one. The fetuses may arise from one or more zygotes and are usually separate but may be conjoined. Now, in this class, we'll talk about different types of multiple gestation. Some are called dizygotic, some are called monozygotic. Dizygotic means two zygotes are formed. Okay, two zygotes. And from each of the zygote, fetuses would be developed. Whereas monozygotic means one zygote is formed in the beginning, then that zygote would be divided, and then different fetuses would be developed. We'll talk about that. Sometime, those zygotes are joined with each other, and they are called conjoined, fetus. You must have seen in a different movie or in different media or something like that. Sometimes the head of the two babies are joined with each other. The head is connected. Sometimes the thoracic cavity is connected. Sometimes abdomen is connected, and sometimes even the lower limbs are connected. This is known as conjoined twins. This is very interesting type of situation. Now, there are two terms which are known as chorionicity and amnionicity. The chorionicity means the number of placenta there, and amnionicity means number of amniotic cavity. So sometimes there are dichorionic, diamniotic twin. Sometimes there is monochorionic, monoamniotic twin. It depends on how many placenta are there and how many amniotic cavities are there. Now, what are the risk factors of a multiple gestation? See there. Okay, let's talk about the risk factor first. The dizygotic multiple gestations are most common than monozygotic one, and the identifiable risk factors include race, geography, family history, or induction of ovulation. Now, it is not in our hand, the race and geographical location, and we cannot even explain why they are so common, but we have to take a very good history in the obstetrical history taking, that is family history. Any birth of twins or triplets or quadruplets or any type of multiple gestation before in the family or not. And another important question is, was the lady using some ovulation induction drug or not? Now, can you give me some of the example of ovulation induction drug? Yes.
Yes, sir. Sir, we've got clomiphene, tamoxifen, sir, letrozole.
Good. That's enough. Okay, very good. Now, I want to say a bit about here. Ovulation induction means, we use a certain drug which increase the secretion of GnRH and follicle stimulating hormone as well as luteinizing hormone from the hypothalamus and the pituitary. We want those hormones to be increasingly, secreted. Now, what is their job? GnRH will stimulate, FSH and LH, and then increase FSH and LH will act on the gonad, in this case ovary, so that those Graafian follicles will be increasingly developed and maturated. So this is the important point. So now let us talk about the negative feedback mechanism there. Regarding the negative feedback mechanism, if estrogen is blocked, that means GnRH is increasingly secreted, and FSH and LH will also be increasingly secreted because of the loss of negative feedback. So if we give certain drug which will block the estrogen receptor, which will modulate the estrogen receptor, then we can get those effects. And clomiphene and tamoxifen are the same type of drug. clomiphene and tamoxifen. Sometimes you can give some drugs which are GnRH analog. GnRH analog, they can also do the same thing. But remember, if you use the GnRH analog for a longer time, then there will be severe suppression of the cycle. Only, for a short duration, like a pulsating activity, we can use those drugs. But more important drug here are clomiphene and tamoxifen. Clomiphene is very commonly used. Now let's move further. Risk of twinning is up to 10% with clomiphene citrate and up to 30% with human menopausal gonadotrophin. So let me explain this again. So see there, clomiphene citrate is one of the drugs which I'm just talking, and another one is human menopausal gonadotrophin. That is, the chance of having twin is 30% with that drug. Now, what is this? Let's talk a little bit about it. Now, what happens after the menopause? Isn't it? What is menopause first? Yes, what is menopause?
Cessation of menstruation.
It's a cessation of menstrual cycle, sir.
Exactly, very easy. Every student know that it's a cessation of menstruation. That's the end of menstruation in that lady. Now, after that, there will be no secretion of estrogen. Means ovary fails. There's no secretion of estrogen. Okay. Now, if there is no secretion of estrogen, then there is no negative feedback. So let me write the important points here for you. No estrogen there. So no negative feedback to the hypothalamus and pituitary. Now, what happens? The GnRH will be excessively secreted in this lady after the menopause. And these GnRH are present in the urine. Okay, so we take the urine from that lady, we isolate this GnRH, and this GnRH can be used as the ovulation induction agent in some other ladies who are suffering from infertility. So this is infertility medicine. Now, what it does, it's very clear now because this is GnRH. GnRH will stimulate the release of FSH and LH from the anterior pituitary, and that will induce the ovulation. Okay, so this is also one of the common medicine which is used in the clinical practice. This is known as human menopausal gonadotropin. Let's move on further. Monozygotic multiple gestation has no identifiable risk factor because there is only one sperm and one ovum, which is natural as well. Naturally, okay, every month the lady will produce one ovum, and that one ovum is usually fertilized by one sperm. This is a formation of one zygote, but we don't know why this one zygote will divide equally into the two, okay, zygotes later on, and then development of the different baby. So we do not know any identifiable risk factors here. Let's move on. Now, all of you, please focus here. It will explain everything for you. So see this. There is one egg. Egg means ovum, and one sperm. So this is also, natural type of process. But in natural type of process, there is no division of the zygote. Okay, it will develop only into the one baby. But here there is division of the zygote, and see there are formation of two babies. So this is a twin pregnancy or multiple gestation or pregnancy. So in this case, see there the placenta is one. Okay, same placenta, but there are two separate amniotic cavity or sac, and these are known as identical twin because they are developed from only one zygote. So most of the features will match with each other. These are monozygotic twin or identical twin. Now see that on the other side, two egg are fertilized by two sperm. Now this is very common things to happen if ovulation induction agents are used. So they have two separate placenta. Okay, everything is separate here. Two separate placenta. Okay, two separate amniotic cavity. So these are called dizygotic twin. They develop from two different zygote, also known as fraternal twin. and the characteristic feature between them is different. Sometimes the sex is also different. One baby is a boy, another is a girl. Okay, so they look different. So these are dizygotic twin. Monozygotic twin usually look similar. Now, how to diagnose multiple gestation? So it is diagnosed by obstetrical sonogram or ultrasound. This is very easy diagnosis. Even during the clinical examination, we can suspect because the abdominal size looks bigger than the normal, because everything is, extra there. The babies are extra. The amniotic fluid is in a large volume. And there are two placenta maybe. So the size may be different or huge, okay, bigger than the normal case. The fundal height is more than the normal. And when we examine the abdomen, we can feel different fetal parts, maybe two head, okay, two head are felt. Then we all know, yes, this is a case of multiple gestation, and the confirmation is done by ultrasound. Now, what are the complications of multiple gestation? Is it a good type of pregnancy or not? Let's talk about it. For all twin pregnancy, these are the complications which are included. Nutritional anemia like iron and folic acid. Now you just think about, there are two babies now and everything has to be divided between the two babies. So one baby may get more substance than the other. So that, depleted baby may suffer from nutritional anemia. Another is a preeclampsia. Preeclampsia, we have already, discussed this in the previous classes. Preeclampsia is another term for pregnancy-induced hypertension with proteinuria. Okay, with proteinuria. So there is a higher chance. Preterm labor or preterm delivery has got higher chance. You don't need to remember the percentage here. There are higher chances of congenital anomaly or abnormality, again because of the unequal distribution of the substances during the development. Now, another is IUGR. Okay, one of the baby may be much smaller than the other, or sometimes both are smaller. Just think about a situation. Normally, the baby's weight is between 3 to 4 kg. Now, that 3 to 4 kg is divided between the two babies here, or if three babies are even smaller than that, So IUGR is quite common. Abruptio placentae is a premature separation of the placenta can also occur. Malpresentation of the baby can happen. Malpresentation means not the cephalic, some other, types of presentation like breech presentation, okay, transverse lie causing shoulder presentation like that. Cesarean section delivery is quite common in case of multiple gestation. You can consider that as a complication because there are more chances of complication during cesarean delivery than the normal delivery, and there is higher chance of postpartum hemorrhage because the uterus is over distended. Over distended uterus can become atonic, and after the delivery of the baby, okay, uterus may not contract properly. So these are some of the complications which are known. And one of the advantages is also there, isn't it? In one setting, the family may be completed because the parents wants that. Yes, we have two babies at once. So this is a advantage we can talk about. Let's move on. Now see there, okay, the same type of complications are listed here in another form or another way. These are the antepartum complication, these are the intrapartum, and these are the postpartum. Antepartum means before the birth of the baby. So anemia is increased, there is high chance of preeclampsia, there is high chance of gestational diabetes, and there is high chance of thromboembolism. Okay, don't need to remember this times, how many times it is common. Regarding the intrapartum, preterm labor, malpresentation, and cesarean delivery. And regarding the postpartum hemorrhage is quite common. The same thing, you don't need to, present like this. You can simply present in the, just like the previous slide. Now let's move on. Let's move to the interesting, part of this lecture. What are the characteristic feature of dizygotic twin and monozygotic twin, and how they are going to be developed? Now, dizygotic twins means they arise from multiple ovulation with two zygote. Okay, multiple ovulation with two zygote. See there. So there are two ova, there are two sperm, and there are formation of two zygote. And they are always dichorionic and diamniotic because everything is different. There are two placenta. That's why we call it dichorionic, because remember, placenta develops from the chorion. The parent substance is called chorion frondosum, okay, and decidua basalis. These are the basic substances from where placenta is developed. That's why we use the term dichorionic, two placenta, diamniotic, two amniotic cavity. So this is called dizygotic twin, also known as fraternal twin. What about the monozygotic twin? They arise from one zygote. One sperm combines with one ovum to form one zygote, and after that, the monozygotic twin may develop. Now, the interesting thing here is chorionicity and amnionicity vary according to the duration of time from fertilization to cleavage. Now, cleavage means division. So, how many chorion would be there? How many amnion would be there? It depends on at what time the division occurs. Now, if the division occurs up to 72 hours, okay, means up to 3 days after the fertilization, that is up to the morula stage. Now, you all know morula means the cells are exactly 16 in number there. 16 number cells is called morula stage. That occurs within 72 hours. Now, if division occurs there, what happens? The twins are dichorionic and diamniotic. There are two placenta and two sac. This is the lowest risk of all monozygotic twin. So it almost looks like, okay, a dichorionic diamniotic twins of dizygotic type, but actually these are the identical twin because they develop from one zygote, though they have two chorion and two amnion. It all depends on what is the time, the division of the cells occur. If it occurs within 72 hours, this is the result. Move on. Now, if the cleavage or the division occurs between 4 and 8 days, okay, between 4 and 8 days, now what will happen? Now, see this separation at the blastocyst stage. This is called the blastocyst stage. Then, if the separation occurs here, the twins are monochorionic twins. Monochorionic twins, but they have two amniotic cavity. This is known as diamniotic. So monochorionic because they have one placenta, and they have two amniotic sac or two amniotic cavity, so they are diamniotic. Now, one special problem here is known as twin-twin transfusion syndrome. Twin-twin transfusion syndrome, TTTS. What does that mean? Now, one baby, okay, may get more blood flow or more perfusion than the other. So these twins share a single placenta, but so unequally. The single placenta, so the amount of blood which goes to one baby is more than the other. So what will happen now? One baby will be bigger than the other. One baby will be plethoric and another baby is anemic. Now, you all know the meaning of plethora, isn't it? The baby looks red. The baby is polycythemic because that baby is getting more blood. So everything is more in that baby. The baby looks bigger than the other one. But it is very interesting to know a lot of complication can develop in that big baby than the smaller baby. Okay, we'll talk about that a little bit later on. Now, see this? Okay, we talk about twin-twin transfusion syndrome now. The donor twin gets less blood supply, resulting in growth restriction. You can call it intrauterine growth restriction or retardation. Also suffer from oligohydramnios and hypovolemia as well as anemia. So everything is lesser here. However, the neonatal outcome is usually better. Okay, what does that mean? After the birth, this baby can quickly catch up if we give good nutrition. the baby can grow faster because this is IUGR baby. And IUGR baby grow very well if we give good amount of nutrition. Whereas the recipient twin, okay, recipient twin means the twin who is getting more blood flow from the placenta or from other baby, you can say like that, resulting in excessive growth, polyhydramnios, hypervolemia, polycythemia, congestive heart failure, as well as hypertension. It is all depends on excessive blood flow to that baby. That's it. Neonatal course is often complicated. Definitely, look at the number of complications here. Hypervolemia can give rise to heart failure. Polycythemia can give rise to thromboembolism. Hypertension itself is quite damaging. So this, neonatal outcome is complicated. Regarding the treatment of twin-twin transfusion syndrome, we can go for endoscopic intrauterine laser ablation at vascular anastomosis. Okay, so endoscopic intrauterine laser ablation at the vascular anastomosis. What does that mean? Before the birth of the baby, when the baby is still inside the uterus, okay, laser destruction of those vascular anastomosis can be done. Means, if there are some more blood vessels which are going towards one baby, you can discontinue that. Now let's move further. Another important type of discussion is some other types of monozygotic twins, like if the cleavage or the division occurs between 9 and 12 days, that is at the phase of embryonic disc. Now embryonic disc, I'm sure you know the meaning of embryonic disc. Okay, in the beginning it is bilaminar germ disc. Later on it will be converted into trilaminar germ disc. Now bilaminar means only ectoderm and endoderm. Later on mesoderm will also be added. So that is the period we are talking here. The twins are monochorionic, that is one placenta, and monoamniotic, that is one sac, just one. Specific additional risk are twin-twin transfusion, but particularly more important than that is the umbilical cord entanglement. The umbilical cord, okay, may twist and entangled, and when umbilical cord suffers from that problem, again there will be decreased blood flow towards one baby. This is the highest risk of all monozygotic twin because of umbilical cord entanglement. There is some accident can also happen, means one of the baby may die because of this problem. If the division occurs after 12 days, okay, this is the stage of the embryo now, okay, stage of the embryo, the conjoined twins result, and most often this condition is lethal. Conjoined twins, okay, this is not a good situation to have. The babies are joined with each other, they are joined. Sometimes, okay, the head is joined, sometimes the chest is joined, sometimes the abdomen is joined, and sometimes the lower limb is joined, sometimes the whole baby is joined, a particular surface. So this is called conjoined twins, and to separate them, it is a huge challenge. Yes, it can be done, and it was already done in different parts of the world, but it is really a big challenge. So these are the different types of monozygotic twins. Now let's talk about that again so that you clearly understand what is this concept. Now, please have a look there. So this is the within 3 days, if the division occurs, then diamniotic, dichorionic, there are 2 amnion and 2 placenta, or 2 chorion, you can say. Between 4 to 8 days, okay, 1 chorion, 2 amnion, and at 9 to 12 days, monochorionic, monoamniotic, 1 chorion, 1 amnion, and after that it's a conjoined twins. After that it is a conjoined twins. Now dizygotic twins, okay, are always diamniotic, dichorionic. There's no doubt about it. It is very easy. Dizygotic, diamniotic, dichorionic, 2 placenta, 2 amniotic sac. Whereas monozygotic twin can be anything. They can be diamniotic, dichorionic. They can be diamniotic, monochorionic, and they can be monochorionic, monoamniotic as well. It all depends on at what stage the division occurs. Okay, so this is the take-home messages from this class. So within the first 3 days or 72-hour, dizygotic, dichorionic. See there, up to 8, monochorionic, diamniotic. Then monochorionic, monoamniotic, up to 12 days. After that, it's a conjoined twins. So these all are different types of monozygotic twin. Now let's move further. Okay, see there, the same thing, because this is the most important point here. Other things are quite easy for you to understand, and these are the important question also asked in the obstetrical exam or MCQ paper. So they may ask when dichorionic diamniotic twin may form from monozygotic type of pregnancy. You can answer within 72 hours. That is in the stage of morula. Monochorionic diamniotic up to 8 days, when this is known as a blastocyst stage. Monochorionic monoamniotic in the embryonic disc stage, 9 to 12 days, and after that it's a conjoined twin. All of these are known as identical twin because they develop from same zygote. Now, can you please see here in this picture what is what is the abnormality you can note here? All of you, please focus. What can you see here? Look at the size of this baby. Okay, isn't it? Look at the size. One baby is big than the other. So see this? This is known as more than or equal to 25% size discordance. Means the size doesn't match between them. More than 25% difference of the size. This is called discordance. Concordance means matching. Discordance means they are not matching with each other. Okay. So this baby is polycythemic or plethoric. This baby is hypervolemic. This baby is hypertensive. This baby can have the feature of heart failure as well. Okay, so this baby is a complicated one, whereas this smaller baby is a IUGR baby because everything is lesser in this baby. And for this twin-twin transfusion syndrome to occur, it requires arteriovenous anastomosis, especially at the place of placenta. Now, what are the clinical findings of multiple gestation? Hyperemesis gravidarum is more common from high levels of beta HCG. Quite easy to understand because the placenta may be bigger in size, and larger size placenta will produce more amount of beta HCG. So hyperemesis gravidarum is quite common. This is excessive vomiting during early part of the pregnancy. Uterus is larger than the date. This is known as increased fundal height because there are multiple babies inside. Amniotic fluid volume is also more. Maternal serum alpha fetoprotein is also excessively high. So these are some of the important points. Now, how to manage? Okay, we are reached to the end part of this small topic. Regarding the management, we divide this into three different groups: antepartum management, okay, intrapartum, and postpartum. Now, antepartum management, we have to give iron and folate supplementation to prevent from anemia, which is very common in the multiple gestation because that lady is having 2 babies or sometimes even more than that. Monitor blood pressure to detect preeclampsia. We always do that. And preeclampsia means if there is excessive, rise in blood pressure or sustained increase in blood pressure after 20 weeks of gestation along with proteinuria. Educate mother regarding preterm labor symptoms and signs, which is quite common in case of multiple gestation. So she should know about the labor pain. She should know about the leakage of amniotic fluid. So when that happens, she should quickly report to the hospital. Perform serial ultrasound examination looking for twin-twin transfusion. So how do we know that? Just now we talked about that. There is a difference between 25% size, okay, between the baby. That is called greater than 25% discordance in fetal weight and amniotic fluid discordance. It doesn't match. One baby looks bigger than the other. This is the result of twin transfusion, and then we can send them to a higher center so that endoscopic laser ablation surgery can be done. Okay, so the chance of complication would be less. Now, what we do in the intrapartum stage, intrapartum means at the time of delivery, how the delivery is done. The route of delivery is based on presentation during the labor. Presentation. So if both babies are cephalic presentation, we can go for vaginal delivery. If both babies are, are coming down with the head presentation, then it is easier for us to deliver. Cesarean delivery, if first twin in non-cephalic presentation, for example, first twin is in the breech presentation, first twin is transversely located, we don't have any option than going for cesarean section. Route of the delivery is controversial if first twin is cephalic and the second twin is non-cephalic. Now, this is why this is controversial, let me explain. The first twin is easily delivered because it is cephalic. But what about the second one? The second one, the presentation of the second can be modified by, putting the hand inside the uterine cavity, and that obstetric surgeon can do that. But that can be a bit complicated sometimes. So if they are, suspicious about this, then they can go for cesarean delivery right in the beginning. Okay. But sometimes they can, take the challenge, deliver the first baby easily, okay, modify the presentation of the second one, and they can go for vaginal delivery as well. So it depends on the treating doctor there. Now, regarding the postpartum management, regarding the postpartum management, now see there, watch for postpartum hemorrhage from the uterine atony owing to an overdistended uterus. I already talked about this, because the uterus is overdistended as a result of multiple gestation, as a result of large amount of amniotic fluid. Okay, everything is more there. So after the birth, the uterine contraction takes time, or it may not contract at all, resulting in severe type of postpartum hemorrhage. So we need to take care of that.